Thank you so much. It's a pleasure to be here. I would say I am not an expert in ovarian tissue transplantation, and I'll present kind of what I know, but I think that this is really an opportunity for us in the United States to learn from all of the work around the globe and bring some of the knowledge back here to start implementing these techniques, which are really, I think, underutilized. So thank you. I have nothing to disclose. So my objectives of this talk are really to discuss some of the indications for fertility preservation, which have really expanded dramatically, discuss some of the options available, which we've heard a little bit about already. I'll talk a little bit about egg freezing, since that hasn't been a focus of this conversation today, and mostly talk about ovarian tissue cryopreservation, not only the freezing techniques, but also the techniques for transplantation, which has resulted in the most success. So the potential indications for fertility preservation have just blossomed, I would say. A lot of us here in the room see patients facing gonadotoxic therapies for medical diseases, including cancer, but other diseases like lupus nephritis, hematologic conditions like sickle cell anemia, thalassemias are treated with cancer therapies like chemotherapy and radiation, and so therefore those patients experience some of the same toxicities. In addition, patients are facing oophorectomy for prophylaxis of diseases. So we see a lot of patients with BRCA mutations, for example, or sometimes the ovaries are removed for benign conditions. And more in collaboration with the Children's Hospital, I'm seeing transgender patients, particularly females, transitioning during adolescence or early adulthood to being male, and interested in ovarian suppression, androgen therapy, and ultimately these patients may pursue gonadectomy, which could permanently sterilize them. So these are potential candidates for fertility preservation techniques as well. We also have to remember that now, with the advent of genetic testing during pregnancy, for example, we're diagnosing Turner syndrome earlier and earlier. So we're seeing those patients when they still have some reproductive function. We're seeing a variety of patients with other mutations that are associated with premature ovarian insufficiency and infertility, and some rare endocrine conditions like galactosemia and polyendocrinopathies, which are also associated with ovarian insufficiency. And then finally, probably the biggest group of patients that we as reproductive endocrinologists see now are women who are aging and worried about their future fertility. And so they are pursuing things like egg freezing more and more every day. So with respect to cancer therapies, I think Richard Anderson will talk a lot about this afternoon, so I'm excited to hear that. But I think this slide kind of presents an overview of how cancer therapies kind of affect the ovarian reserve. And so cancer therapies, particularly alkylating agents and pelvic radiation, essentially destroy follicles within the ovaries, reducing the total available pool of follicles in a woman's ovaries. And depending on the timing and the exact type of exposure, the clinical outcome could range anywhere from pubertal failure to early ovarian failure, early menopause, or infertility. And as we've heard over the past 10 years, during kind of this Oncofertility Consortium explosion, I think we have seen the incredible advancements of reproductive techniques. We just heard from Lynn Westphal about embryo freezing. It works incredibly well, and it's just getting better with things like vitrification. Egg freezing is also now an option for women without a partner, and also ovarian tissue cryopreservation is a real option for patients. So I think the greatest advent in my mind over the past 5 years in reproductive medicine has really been the ability to successfully freeze and thaw eggs from a woman's ovaries. And, during this, I think I remember we started this consortium, in 2006, I think it was, right? And in 2012, in the fall, I think around the time of the conference, the ASRM came out with the guidelines saying that egg freezing should no longer be experimental. So that was a huge win, I think, for all of us, because in particular, they said even then that in patients facing infertility due to chemotherapy, oocyte cryopreservation is recommended with appropriate counseling, obviously. So where are we today with egg freezing? As Lynn Westphal mentioned, the data in a variety of different populations, I think, is really lacking. While a lot of women are freezing their eggs for cancer, for other medical indications, and just to use themselves later on because they're aging, a lot of those women are not actually coming back to thaw the eggs. And so we don't have a lot of good data about the success rates. The population of patients who we actually have data in are the donor egg population, so recipients pursuing donor egg because they have ovarian insufficiency themselves or are older women. And so we can look at 2016 SART data and see that almost half of all of the donor egg cycles in the United States were actually using frozen donor eggs. So over 3,300 cycles of frozen donor eggs in 2016 compared to about over 4,600 of recipient cycles using fresh eggs. On average, 1.5 embryos were transferred in these cycles, but you can see the live birth rates per cycle and per transfer were 36% and 44% using frozen eggs, compared with 50% and 55% using fresh eggs. And we could talk all day about why this is, how we can make it better. It is still, the reality is in practice, egg freezing is a little less successful than embryo freezing. It still does work very well, and it's a great option for patients. And really, it is the number one option, I would say, we offer to our young patients who are not in a very, very committed relationship, because we have to remember that those patients will come back and maybe in 5-10 years may want to use their embryos or gametes, and if they've broken up with that partner, you know, there are issues. There have already been several lawsuits related to embryo ownership in cancer patients who have then split up with their partner. So egg freezing really has solved that problem for us, even though maybe it isn't quite as successful in practice. We can get through the process very quickly, usually within 2 to 3 weeks. We can put a patient through stimulation and harvest eggs. It is a proven technology, particularly in young patients, as I mentioned. It's also very beneficial because when patients come back to use their eggs, if they're found to have a genetic mutation, like a BRCA mutation or a Li-Fraumeni mutation, which are related to cancers, then we can thaw those eggs, fertilize them, create embryos, biopsy the embryos, and test the embryos to see if they carry that particular mutation to avoid passing it on to the subsequent generation. The other thing that's very helpful is the fact that these eggs can be used in a gestational carrier later on, which is a really common solution for many cancer patients that I see. The disadvantages of egg freezing, unfortunately, we don't always get a great number of eggs through one cycle of stimulation, so there are a limit to the number of eggs we can get. It's a pretty complicated process. It takes a couple weeks a minimum. It's expensive, at least in the United States, where often it's not covered by insurance. And after exposure to chemotherapy, often a woman's ovaries do not respond to stimulation, and we don't really know the safety of those eggs, even if we are able to get eggs after stimulation. And the other major population is the fact that pre-pubertally, it's not possible to stimulate a girl's ovaries and actually acquire mature eggs. So there are definitely issues with egg freezing. Ovarian tissue banking, on the other hand, is much simpler. Really, the advantages are that you can do one procedure and potentially cryopreserve thousands of eggs at one time. It's a very simple procedure. I'll show you, pictures and videos of both the removal of the tissue as well as the transplantation of the tissue. So I think that anybody who does surgery could do this very simply. It's quick. There's very little delay in starting therapy. You can even do this after a round of chemotherapy that's not sterilizing, especially in patients who are facing more high-risk treatment like a bone marrow transplant later on. And it's really the only option available for prepubertal girls. Teenagers as well often do not want to go through stimulation themselves, and so this is a pretty good option for teenagers who really don't feel comfortable going through the process of egg freezing. What are the disadvantages? You need to do surgery to not only remove the tissue, but also to replace the tissue later on at this point. We'll talk a little bit about the potential risk of transplanting or reseeding the body with the cancer cells if they're resident in the ovaries. And another major challenge, I think, is the fact that it's not so easy to do IVF after ovarian tissue transplantation, so it's difficult to get eggs and embryos for testing for pre-implantation genetic testing, for example. It's also difficult to get embryos in order to use in a gestational carrier in the event that the patient is not a good candidate for pregnancy herself or if she's lost her uterus. If we were able to develop the technology of in vitro maturation to the point that it would become clinically available to RISA, then we would be set. So according to the ASRM, this technique, ovarian tissue cryopreservation and transplant, should be offered to carefully selected patients, still as an experimental protocol. We're coming out with a new document soon, so we'll have to see what that says. But nonetheless, it really is a second-line therapy after non-experimental techniques like egg or embryo freezing. And again, outlining that particularly patients who are prepubertal, those with hormone-sensitive malignancies, those anticipating stem cell transplant, which is highly gonodotoxic, or those with genetic mutations that potentially pose a high risk for premature ovarian failure are all potential candidates for ovarian tissue cryopreservation. So I wanted to just present a case of, just to illustrate one scenario that I had that really highlights the importance of offering this technique to patients and how it does, I think, fill a gap, which egg freezing doesn't always work for everybody. So this was a 35-year-old married nulliparous female who presented to her primary physician with shortness of breath, dry cough, night sweats, and chest discomfort. She had a chest x-ray which showed a 10-centimeter mediastinal mass, and then a PET CT demonstrated pancreatic and liver infiltration with tumor. They did a mediastinal biopsy which showed a large B-cell lymphoma. So she was having significant respiratory symptoms and so therefore was hospitalized immediately with the intent of starting chemotherapy right away with R-CHOP. She, of course, was, highly educated and very worried about her future fertility. So on Thanksgiving Day, 2009, I got a call, and I remember I was in a parking lot at my parents-in-law's house in Connecticut, and she was desperately hoping to talk to somebody about fertility preservation options because she was refusing the chemotherapy. So we talked a lot about, the moderate risk infertility and ovarian failure. I had no idea what her ovarian reserve was at that time. All I know, she was 35 years old and she was getting this regimen. The bottom line was she didn't have a lot of options. We didn't have 2 weeks to stimulate her ovaries and get eggs. So essentially we said, you know what, we can't put things on hold, get a round of chemotherapy, and then we have a protocol through the Oncofertility Consortium, and we can freeze ovarian tissue once some of your symptoms are improved. So that's what she did. She came in, and after a round of chemotherapy, we ended up doing a laparoscopy and we obtained an ovarian biopsy. Now at that point, we did not know her AMH result, which was 0.3. I don't think it necessarily would have changed anything other than the fact that maybe we would have taken an entire ovary and not just a piece. But at that point, we were doing studies of ovarian reserve, and so we were taking research samples before treatment, and so we didn't have that number clinically available. Nonetheless, we took her to the operating room, removed about a third to a half of her ovary, processed it, froze it using the slow freeze technique, which was published, I guess, in 1994 by Gosden's group, and put the tissue away. 3 years later, she came back. At that point, she was on hormone replacement therapy for, symptomatic relief. She was postmenopausal. We stopped her hormone replacement therapy, reassessed her hormone levels. Her FSH was over 100. Clearly she was menopausal. She was not having any periods and having, symptoms of menopause. And we talked about her options to have a baby, and she really wanted to try to have the tissue transplanted before pursuing any other options like egg donation. We had no IRB for transplant. So then we said, okay, let's write an IRB. So we wrote an IRB. We had it approved. She patiently waited for us. We had her see her oncologist. We had her see the high-risk OB. We had her do psychological counseling. Got a semen analysis on her husband. Everything went well. She was healthy, no evidence of disease, and everybody gave us the thumbs up to move forward. So we took her to the operating room. We, at that time, ended up doing a hysteroscopy to look at her uterine cavity. We did a laparoscopy. We flushed her tubes to make sure they were open. And then we basically took all of the tissue that we had frozen. We thawed it according to the protocol, which is a very simple process. And then we basically took that tissue and we opened up her ovary, exposed the medulla, and then placed the pieces of tissue actually on both sides. We just transplanted all of it. At this point, we knew her AMH had been 0.3, so I was I didn't think really this was going to work, but I said, okay, we'll do it, make her happy, see what happens. Amazingly, over the next 6 months, we watched her every month with hormone levels and ultrasounds, waiting for something to happen in her ovaries. Her FSH level did drop from 130 all the way to kind of less than 10. Her menopausal symptoms improved. She began menstruating, and actually we were able to capture an ovulation and did an insemination with her husband's sperm. She did not conceive, and then shortly afterwards, she became menopausal again. So the tissue was very, very short-lived. She ended up moving on, doing egg donation, and now has delivered 2 healthy children. So she's very happy, and the story ended well. It's not her own genetic child, but I think that she was actually glad that we went through this whole process with her, and she was able to try to have her own genetic child. But through this process, we learned a lot, and I'm happy to share any of that information with any of you, including the IRB-approved transplant protocol, which I've already shared with Kyle over there. And since that time, since 2004, there have been a number of live births now from orthotopic autologous transplantation. And if you haven't read this paper in the New England Journal by Donna, you should. I think it's a nice summary summarizing kind of over 130 live births to date. It's important to recognize that most of those births have not occurred in the United States. Most of them are outside of the United States. Again, we are really not doing much of this in the US. And there was a nice meta-analysis that was put together trying to really get an estimate of what the success rate was for ovarian tissue transplantation. So this study looked at 309 transplants in 255 patients. On average, patients were 29 years of age at the time they froze the tissue, 33 years of age at the time they thawed and had the tissue transplanted. Over 63% of the patients ended up having some endocrine function, and there were 65 pregnancies in 172 women, so 38%. And when we look at just one pregnancy per woman, because that was a cumulative pregnancy rate, 28% of women, or 49 out of the 172 women, had at least one pregnancy. So the number that Teresa quoted of 30% is about where we are. Most of these have been unassisted conceptions. And while we could argue that their native ovary might have been in place in some cases, was it really from the transplant, was it not, et cetera, I think as data continue to accumulate, we can say that this does work, and it's a valuable technique. So how about the comparison of eggs versus tissue? Well, which one's better? Again, very few people have come back to use their eggs and tissue, but the EV group in Spain had about 7% of their patients came back to utilize their tissues or eggs since 2005, and so they published this report recently showing that when patients used eggs to conceive, the 49 patients who came back, 20 out of the 49 achieved pregnancy, and 16 of the 49, or about 33%, actually had a baby from their frozen eggs. When we look at those patients who had ovarian tissue, 34% achieved a pregnancy from a tissue transplant, and 23% ended up having a live birth from transplanted tissue. So the number was lower, although it still did work in over 20% of the cases. So this group felt that this kind of validated their practice of trying to freeze eggs before tissue, which I think we all agree with, but if you can't freeze eggs for whatever reason, tissue is definitely a good option. And I think it also begs the question of, should ovarian tissue cryopreservation and transplantation still be considered experimental? Is it ready for prime time? Would that help get it covered in the United States? I think all of those are excellent questions, and I think we need to sit down and really work on a document to make a case for it. Nonetheless, Dror Miro in Israel was able to argue to the Israeli government to have ovarian tissue cryopreservation part of the standard health plan and covered by the health service there. So now I'm going to transition to showing you some videos of transplantation techniques. I am extremely grateful to all of those people who I reached out to who have given me their videos in order to show them to you guys and share the wealth of information, since again we want to move the technology forward here. So two of the first two, Ralph Dietrich and Michael von Wolf, are from the Fertility Protect Network. Dror Miro from Israel, Sherman Silber from St. Louis, and Kutluk Aktay, who's now at Yale. So first we'll start with two videos from the Fertility Protect Network, just to give you a little background about this network. Essentially, 3 countries got together and formed this network in 2006. So Germany, Austria, and Switzerland have 101 centers now in total who are able to acquire tissue and then send it to other centers to process the tissue and freeze it. So far, they've collected over 2,500 ovarian tissue samples in cancer patients, and as of 2016, when they published their paper, they had done 74 transplants. They found, similar to the meta-analysis, over 65% of patients who had a transplant actually had hormonal function at a year after the transplant, and 17 of the 74, or 23%, achieved live births. When they restricted the analysis to only those 40 patients who had one transplant and had a diagnosis of premature ovarian insufficiency, they found that 9 out of those 40, or 23%, ended up having a baby. Interestingly, none of the patients who had been exposed to pelvic radiation actually conceived in this whole study. And I think that's probably because radiation does damage to other organs like the uterus, which can impair the ability to carry the baby, as well as it can affect the tissue and potential engraftment of the ovarian tissue after transplant. So from their experience, they came up with some guidelines, which I think are helpful to share. They believe ovarian tissue cryopreservation should be only offered to women less than 40 years of age, ideally less than 35, but definitely no more than 40. Ideally before exposure to chemotherapy to maximize the number of follicles collected, but it could be performed after some exposure to chemotherapy, again in the setting of the patients getting additional highly toxic therapy. In general, a laparoscopy should be done to remove the tissue. Sometimes a laparotomy would be already being performed for treatment of the cancer, and then obviously a laparotomy would be reasonable, but generally laparoscopy should be performed. Ideally, it could be coordinated with another procedure, and these cancer patients sometimes have bone marrow aspirates, port placements, other procedures that you can kind of latch onto. And we have also observed that when you take tissue from ovaries with cysts, there is the distribution of the follicles, they're spread out, so you don't get as many follicles per surface area of tissue. So if you have a choice, take tissue from the ovary without the cyst. Use cold scissors to remove the tissue, not cautery, because it will cause destruction of more follicles. You should remove at least 1/3 to an entire ovary, depending on the gonadotoxicity of the treatment and also the patient's age. And they recommend sending a small fragment to pathology to document the presence of follicles and also to see if there's any evidence of metastasis. A courier is required to take the tissue from the operating room to the laboratory, and in Denmark, as well as in the Fertility Protect Network, they've actually used couriers and shipped at basically 4 degrees centigrade, even overnight, and there's been documented pregnancies from this tissue that's been transported for hours. So it is possible to transport tissue. In terms of the dissection techniques, the important thing is to dissect the tissue so that it is thin, 1 to 1.5 millimeters in thick. The width doesn't really seem to matter as much. Could be 5 millimeters, 10 millimeters wide, depending on your technique of transplantation. We use a tissue slicer, which you can buy on Amazon. It's actually very, very helpful because it makes very uniform slices. Mary Zielinski recommended that. And then there is a lot of controversy about the best technique for freezing. We continue to slow freeze tissue, and most of the Europeans still slow freeze their tissue. The problem is that you need a slow freezer, which really has almost become extinct in the United States, it sounds like. So vitrification is definitely another option. There have been births from vitrification, and Mary Zielinski is working on getting some media prepared so that we can all use a vitrification media. But we've done vitrification with media that we've used in our lab, and it seems to work just fine. In terms of transplantation, really, patients should only have a transplantation in order to achieve a pregnancy. It does it because we can't guarantee that the tissue is going to last years and years and years. It's not really worth transplanting just for hormone replacement therapy in most patients. And it's important to do an assessment of the patient or couple's fertility, get a semen analysis, do a uterine and tubal assessment, either before or at the time of the surgery. Obviously, investigate if the patient's a good candidate for pregnancy. Are they a good candidate for transplant? Talk to the oncologist, figure out what the potential risk is to the patient. And then pretty much it seems like laparoscopy is the most reasonable approach to transplant the tissue. I'll show you some videos of that, either to the pelvic sidewall or onto the ovary. So within the pelvis tends to work best. Heterotopic transplantation is less efficient. Often the tissue is marked with clips, so when you're looking by ultrasound or x-ray, you can then identify where the transplant was. And at least the Fertility Protect Network recommends transplanting about 1/3 to 1/2 of the tissue that you've taken out at a time so that you have more tissue in the event that the patient wants to have another child later on. And then most of these protocols involve monitoring for ovarian function every 1 to 2 months with hormones and ultrasounds post-transplant to assess the presence of ovarian function. The decision of how the patient will get pregnant after a transplant really depends on the fertility assessment. What's the sperm quality? Are the tubes open? And then whether they have decent ovarian reserve. Unfortunately, ovarian reserve is generally very low after transplant, and so patients are not always great options for IVF. It tends to be a very inefficient process to stimulate the ovaries, ovarian tissue, and you get very few follicles at a time. So this is the first video from Ralph Dietrich's group, and what you're going to see is essentially, so for those of you, I don't know how many oncologists or reproductive surgeons, this is the uterus. There's a little fibroid on the uterus. Hold on, where's my thing? This is the ovary. This is the fallopian tube. Right here, he's looking for the ureter, which pops out right there. So just kind of looking at the anatomy here, making sure they're not doing any damage. Basically takes a piece of peritoneum and then just makes a little window in the ovarian fossa here. This is an extremely simple approach. I think when I heard him talk in Vienna, somebody in their group talk, he said it takes them 5 minutes to do the transplant. So basically just creating a space and then taking the tissue, little fragments of tissue after they're thawed, essentially trying to put the tissue with the serosal side towards the peritoneum and trying not to just clump them on top of each other, putting them next to each other. Again, just putting them all in. And then here he doesn't show that he closes the space. Some people do put a stitch over the space. I think he just leaves it like this. Other people put clips right over the space so that then it closes it, and also it shows you the site of the transplant. And then here he's just flushing the tubes to make sure the fallopian tubes are open. And then he's going to just take off a fibroid while he's here, just for kicks. It's probably unnecessary from a fertility standpoint, but it certainly is easy to do, and so that's it. Okay, so let's see. Okay, so now this is Michael Van Wolf sent me this video. This is the same Fertility Protect group. They actually were doing a trial to do the peritoneal incision, and then they were doing the ovary on the other side, and they were going to kind of compare the follicular development. But here's a picture of a video of what the ovarian transplant looks like. This is a little more complex. So makes a little incision in the cortex. Again, using cold scissors. You don't even need cautery. And then taking 2 stitches of 6-0 PDS, and then just suturing the pieces onto these little pockets. And again, trying to keep the inner part of the tissue, identifying what the serosal part of the thawed tissue is, and the medullary side, and then trying to keep it in the right orientation. This is just definitely a little more complicated. You have to be comfortable suturing. So you could do extracorporeal or intercorporeal. That's what they recommend overall in their guidelines, is putting, what did I say, half to a third of the tissue at one time. Yes. Any way you do it, either the ovary or the peritoneum. Yeah. Yeah, and here's a picture of what they did on the left side. They made the peritoneal whole, but then sutured, put one little stitch over it. I don't really think it's necessary to close it. But this is what the ovary looks like afterwards. So it's kind of like a mattress. This is definitely, you have to be more skilled to do this case. So Dr. Shah will be doing them in our institution. Okay, so the Israeli center, Dr. Miro, also gave me a video, and he also gave me some slides telling me their success rate. So he apparently has performed 31 transplants. He prefers to transplant the tissue onto the ovary using what he calls a tunnel technique. Of the 31 transplants, 13 pregnancies overall, so 42% pregnancy rate. Young women, as expected, have a much higher pregnancy rate, 48%, compared to older women who are over 35, 17% pregnancy rate, which is why some people don't do this over the age of 35. And interestingly, in his population, I think he has a lot of patients who are pre-transplant, who get some chemotherapy, and so almost half of his patients had been exposed to some chemotherapy previous to the acquisition of the tissue, and 61% of those women actually conceived. So exposure to chemotherapy is not necessarily a problem. And when we're dealing with kids, often you see them after a round of chemo, and I still think it's okay to take the tissue based on these data. So here is the ovarian tunnel technique. Okay, so here he's making he kind of makes a hole in the cortex, but then digs in there a little bit. So it's similar to the last one. But then what he does is he takes a stitch to hold the ovary and then also to close the space afterwards. And when I asked him what stitch he used, he said 4-0, doesn't really matter what you use. He does an extracorporeal tie afterwards. So after he does this little tunnel, puts the stitch in, and then actually puts the tissue inside that space, then he just ties that area closed. So again, this is a little simpler than the last ovarian transplant we saw, which was, I think, took a little bit more expertise. And then I was going to show a YouTube video of, so Sherm Silver from St. Louis advocates a microsurgical technique where he uses a 9-0 nylon to essentially mattress together the little pieces of tissue, and then he takes that and does a mini laparotomy and transplants it onto the ovary. Now, he's been doing microsurgery for years and years and years, so his approach is a little different, but you can play it. Okay, so just 9-0, putting the little pieces together, using heparinized saline to get rid of any blood clots, fibrin deposition, anything like that. So then after he has that little mattress, he does this mini laparotomy with this retractor that he uses. He exposes the ovary, and then essentially he does, under the dissecting microscope, he's essentially doing, the operating microscope, he's essentially putting mattress sutures down and really getting a tight connection between the medulla and that tissue. And first he decorticates it, which you didn't see there. And he is a real believer in the microsurgical technique and thinks that you get more, engraftment and follicular survival. I don't think we have enough information about different approaches and about the outcomes to really tell us that level of detail, but it's certainly much more challenging to do it his way.
Technique 1.
So this is thanks to Kutluk Aktay at Yale. He did a presentation at ASRM this past fall, and he showed a technique where he uses alloderm. So he takes the little pieces, puts them first on alloderm, and then sutures the alloderm into different spots. So there's 2 videos here. Again, I think it makes the surgery easier in some respects because you don't have to take all the little pieces one by one. So you can take a look.
The transplantation to contralateral ovary using robotic assistance and alloderm. In this approach, the contralateral menopausal ovary is bivalved to create a larger and vascular surface for transplantation. To achieve this, we use robotic scissors and avoid any cauterization on the ovary. In the meantime, ovarian tissues are thawed. These are then sutured onto alloderm under a microsurgical microscope using 5-0 monofilament delayed absorbable sutures. The cortical pieces are sutured so that the stromal side of the tissues are facing away from the scaffold. The alloderm scaffold is finely trimmed to leave approximately 5 mm tissue-free rim for manipulation of the graft and suturing. Please note that the size of the final graft is predetermined by our preoperative ultrasound evaluation of the ovarian surface area, taking into account the bivalving. After the simultaneous preparation of the contralateral ovary by bivalving and reconstruction of the ovarian graft, the graft is introduced into the abdominal cavity through a 12 mm access port. The graft is then juxtaposed onto the bivalved ovarian stromal surface, with the stromal side of the ovarian feces facing the vascular ovarian bed. After anchoring the graft to one of the poles, the graft is anastomosed to the recipient ovary using a 4-0 V-lock suture in a running fashion.
So he uses a V-lock, so he doesn't need to basically tie anything off. It keeps it in place. There's little barbs on the. Looks pretty good. Again, we were having a discussion with Mary over here whether it is better or worse in terms of the engraftment, because now you have a barrier to engraftment. So again, I don't know.
The abdominal wall is inspected, and the most suitable site is determined to facilitate future access to the graft for percutaneous oocyte retrievals.
So this is
to ensure correct localization.
More of a heterotopic transplant that he's doing. And the reason in this patient is that she had a TAH, BSO, and pelvic radiation. So there's no place in the pelvis to really transplant it, and they need IVF anyway. So they're basically making a pocket under the peritoneum, so that, and placing the tissue so that they can then do IVF and retrieve the eggs easily.
In a similar fashion to the prior case, is brought into the abdominal cavity via the 12 mm access port. Then the graft is inserted into this pocket with stromal sides of the ovarian cortical feces facing the rectus abdominal muscle. The graft is then attached to the peritoneum using 4-0 V-lock sutures. These sutures are then secured in place using laparoscopic absorbable lapra tie clips. We then close the peritoneal defect using the same suture material in a continuous fashion. Finally, titanium clips are applied around the edges of the graft to enhance future radiographic localization of the transplanted tissues.
So I think those give you an idea of what it's involved. I think you can go the very easy route, which is just putting it in the peritoneum. You can go the more complicated route. Time will tell what is more effective, but I think any surgeon can do one of these approaches, and I think that's the bottom line. So our biggest concern, which we mentioned earlier, is the risk of reseeding cancer cells, which really became a concern, I would say, around 2010, when there were some cases where leukemic ovarian tissue was placed into a mouse model, and then there was evidence of tumor growth. And so kind of alarm bells went up saying, wow, this is really unsafe to transplant tissue from patients with leukemia who have a liquid tumor, and these cells could be anywhere in the body, including the ovary. And there is concern, particularly in situations where tumor cells could be resident in the ovary. So leukemia, ovarian cancers, patients with BRCA mutations who are at risk for ovarian cancer anyway, and then other potential cancers that can metastasize to the ovaries, like gastric, endometrium, or colorectal cancers. And there have been a variety of methods proposed to screen the tissue, anywhere from taking fragments of the cryopreserved tissue, looking under the microscope and looking at histology to identify cancer cells, doing either FISH, PCR, next-gen sequencing, if there are particular molecular markers in the tumor cells that you can look for. And another approach is taking a fragment of the tissue and doing xenotransplantation in a mouse model to determine the safety before you transplant the rest of the tissue into a patient. And that is exactly what Dror Moreau did. And last year, it was very exciting. He reported the first delivery of a baby from ovarian tissue transplant in a patient who had cryopreserved her tissue in the setting of leukemia. Now, she had gotten chemotherapy and was in remission prior to a bone marrow transplant, and that's when the tissue was acquired. Typically, the ovaries are cleared of cancer cells at that point, which is why we think it's probably safer after a round of chemo to take the tissue in leukemics. Nonetheless, he evaluated the tissue in a variety of ways. He took a fragment of tissue and xenotransplanted, waited 6 months, made sure that there was no evidence of tumor in the mouse model, and then he took the rest of the tissue and transplanted it into the patient. She's now had 2 deliveries of healthy babies, so I think that was a great success, and at least it gives us some idea of how we can evaluate this tissue for patients where we're worried. So we started our program in 2007, again in collaboration with the Oncofertility program. We have a very busy program. 3 attendings in our practice, including Dr. Shah, Dr. Sinapati, and myself, see cancer patients because initially I was doing it all, and I can't. We have too many patients to see. We probably have done over 250 ovarian stimulation cycles in cancer patients. We have now done 102 ovarian tissue cryopreservation cases, still only 1 transplant. And we've established a hospital IVF program for sick patients, patients with cardiac anomalies, and other rare disorders who are not candidates for traditional IVF in an outpatient setting, can go through IVF, have a hospital retrieval, and then we can use those embryos to have in a gestational carrier to get pregnant because they're not healthy enough to get pregnant themselves. So this has been an exciting new program, I guess, that's run in parallel with the Oncofertility program. We also take care of men and boys. We do prepubertal testicular tissue banking in collaboration with Children's Hospital, and we also do a lot of third-party reproduction. We have a donor egg bank. We do fresh egg donation. We do a lot of gestational carrier cycles, and a lot of these cancer patients are recipients of these services. Just in terms of our cryopreservation cases, the 102 cases that we've had, mainly we offer this to children and adolescents who, again, are not candidates or don't want to freeze eggs. Many of these patients have been exposed to some chemotherapy already, but are anticipating more toxic chemotherapy. And so that's part of the reason a lot of these patients have not come back, because they're still very young. We have been lucky to have donor funds available through Children's Hospital to cover the pediatric cases. We don't charge for the surgical fee or for the cryopreservation itself or the storage at this point. I think if it were to come off the experimental labeling, that could potentially change. So in summary, I think we've made incredible strides to expand the reproductive options of patients with cancer and other fertility-threatening conditions. I think we really need more global collaboration, not only in research, but in clinical care, so we can really disseminate knowledge and strategies and really spread the word about ovarian tissue cryopreservation and transplantation. And just to leave you with a testimonial from a patient who actually froze her ovarian tissue. As a young, single woman diagnosed with cancer, the scariest part of the diagnosis was the fear that my ultimate goal in life would be taken from me, the opportunity to become a mother. The ability to meet with doctors and discuss fertility preservation prior to treatment offered comfort during a very chaotic time when major health decisions were made in a matter of days. It was reassuring to know that despite the risk of medical treatment, that I still had fertility options when treatment was finished. Thank you very much.